Hello, and welcome to OvaryActive. I'm Dr. Rebecca Dunsmoor-su.
And I'm Dr. Amy Vodish, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause. Welcome back, everyone. This is OvaryActive, and I'm Dr. Amy Vodish.
And I'm Dr. Rebecca Dunsmoor-su, and it is my great pleasure tonight to introduce a friend, but also an expert, both in gynecology, but also really in communicating about medical topics, dispelling myths. I think you all probably know her from what used to be called Twitter. I don't even know what it is anymore. Or you may follow her Substack, The Vagina, which I adore and read every time it comes out. And she also has 3 books, which I went downstairs and got so I can show you all. The first book, The Vagina Bible. The next book, The Menopause Manifesto, which I recommend to all of my patients.
Mm-hmm.
And the one we're probably going to dwell on a little bit more tonight, Blood, about menstruation. So can you please welcome Dr. Jennifer Gunter? And can you tell us a little bit about yourself, your background? How'd you come to this? How'd you come to writing? I mean, what inspired you?
Thank you for having me. It's really nice to be seeing you guys and chatting and catching up. It's kind of like old home week. So how did I get into all this? Well, I got into writing. I never thought I would ever write, but apart from like academic pieces and stuff like that. And then around the Suzanne Summers sort of time with Oprah and all her, when all her books came out and all that kind of, you start to notice this like uptick of stuff in the office and you're like, what is going on? Like, where did you hear this from? And this is obviously like pre-internet, pre-anything, right? And so I would say that her health content about women's health, I struggle to call it content, her disinformation about women's health is probably like the first time anything about women's health really like went viral before things could go viral, right?
Yeah.
It was kind of like fascinating. Like, where are you hearing about this stuff? Like what's going on? And of course, because I wasn't reading People magazine, which, anytime a celebrity writes a book, they get like a megaphone with that and all that kind of stuff. And then I started kind of putting everything together with the idea that we really needed to kind of broach this, what we talk about in the office and how we talk about healthcare with how it's actually lived in the real world. And I don't think medicine really teaches that. We always talk about like bench to bedside, but what does that really mean? And I kind of had a lot of that experience, with my own pregnancy. I had a triplet pregnancy. I delivered very prematurely. I like 23 weeks and one of my sons died. And then I stayed pregnant. I had an interval delivery at 26 weeks. I know probably a lot of OBs listening to this, just like, having like their
our sphincters all went, yeah.
Yeah, everybody's sphincters, right? And then I got delivered at 26 weeks and my sons were 783 grams and 843 grams. And then they had all kinds of health problems. And on top of it all, Oliver had a complex cardiac defect that needed surgery. Like, it's just like everything awful that you could imagine. This was right around the time the internet was starting. And I just sort of really started to see how people could get sucked in. And I got kind of interested, I think, in how the information gets translated because I was very paranoid about like unvaccinated people being around my medically fragile children on oxygen, right? And I just couldn't believe how the anti-vaccine movement had like spread and not just been like when Andrew Wakefield came out, people going, okay, that's like a terrible 8-person case series, or however many people, like, why are we even talking about this? Why are we even having this conversation? So I think like all of these things just kind of coalesced and I thought, someone needs to fix this. So I decided to get online. I wrote a book about prematurity. I got online to kind of try to promote it. And then after my kids got a bit older and there was less sort of acute prematurity related stuff, I thought, oh, let me see what I can do for gynecology. And so I started myself a WordPress blog and I started blogging and I just thought, oh, I'll just write this stuff and people will come and everything will be fine. Because I had no concept of like the malignant forces and the ways celebrities. And so it just started organically. And then after I'd been blogging for a while, I got offered, I had a couple of columns for a while with the New York Times and other outlets. And then I thought, maybe I could put this all together in a book. And then that became the Vagina Bible.
I love all of your books, but I think the Vagina Bible for me is probably the most important one because it's the thing we do not talk about. Menopause is hot now. Everybody talks about it. Still
But
not
when you-
talking about the vagina.
Nope, 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 can't talk about the vag. But
Yeah.
I mean, but when you wrote the Menopause Manifesto, menopause was not having the moment it's having now.
I like to say I started the moment.
Well, there you go.
You
We'll
know,
give it to you.
people always talk about that piece that was in the New York Times, but my book came out a year before that. And I'd written in the New York Times several times about menopause, but you never know what's going to catch, right?
Right.
So,
Totally.
that's just the way it is. I'm pre-WHI. I've been prescribing hormones since I was a resident. Maybe there was a brief hiccup, 6 months or whatever post WHI. And that also coincided to when my children were born. So I don't really remember a lot. If you asked me what I was prescribing at the end of 2003, I'd be like, I don't know. I
no clue.
I have no idea what I was doing with my life.
Yeah.
So, by the time I really got, I was off clinical medicine for about 9 months. So I just didn't realize how little it was being talked about. Because my patients knew about it because I would tell them, but my patients would know about vaginas because I would tell them. And so when I was on tour for the Vagina Bible, people started asking me all these questions about menopause. And I was like,
Yeah.
really? You don't know that? You don't know that? Yeah. I guess it just hadn't really, again, it's that whole bench to bedside moment. You don't know what hasn't permeated. And so I just thought, okay, well, I'll write that book next. Then there was a third book to write because I did a 2-book deal when I said I was going to do Menopause Manifesto. And I was like, okay, we need to make it a box set and let's talk about periods.
Yeah. Perfect.
We're going to make it a box set. Oh, I love it. So I have 2 daughters I've talked about a lot on this podcast who are elementary and middle school age. As part of their schools, of course, there's always fundraisers. And so I often am put in charge of the book brunch where the hosts curate books for people. And so I always have one of your books on the list. And they are the most popular. They're always like, okay, the number 1 book this year was the Vagina Bible and the number 2 book. So now I'm hosting a Margaritas and Menopause, event coming up. And so your books are going to be a part of the choice because I'm also going to let people curate their swag bags.
Oh, fun.
Yeah. So I was like, your books are going to be in there. So it's just, it's so fun to have you on here. And I love many things about you. And I love your snark, and which I also have. And I love your willingness to sort of tackle these myths and misconceptions head on. Because my personal war that I love the best is yours with Gwyneth Paltrow and Goop. And we're not attacking people. I just want everyone to know in this podcast, we will, I'm sure at some point, talk about Oprah's menopause thing. We're not attacking Oprah. It's just more looking at, as scientists and as physicians and the evidence-based medicine, we're really looking at the science that's being presented. And that's our issues, right? And how things are being presented. So one of the fun things I love is how you sort of deal with all these myths and misconceptions. So, and this podcast is focused on perimenopause, right? So is there a favorite perimenopausal myth that you love to dispel?
One of the biggest myths is that, you don't have symptoms until your last period, right? So obviously people can have symptoms before. I always try to remind people it's like puberty, right? Some people grew before they got their hair. Some people got their hair, but it's all a little bit different for all of us. And, we know from studies that there are different trajectories of hormones and things, but it's just, that's why I kind of like to call it all the menopause experience or the menopause continuum, because you never really know. There are people who never get a hot flash. There's people who have them all the time. There's people who don't get symptoms till after their last period. There's people who get symptoms before. And so I just think, that would be the thing, certainly you can get symptoms before your last period.
Yeah.
Oh, yeah.
No, absolutely. And I always sort of my one that I just go on and on about is the thought that if you're on birth control pills, combined hormonal birth control pills, you can't have symptoms. But you're on birth control pills, you're not going to have any symptoms. And sort of talking about yes, you can have breakthrough symptoms even when you're on different types of hormones and different things like that. And so it's kind of part of that idea.
Although I think we've talked about this before on this podcast, that you and I were taught that birth control pills should solve all the symptoms. And it really was with experience and time that we started to see that for some women, it totally does. It's a great solution. Solves every symptom. They're doing fantastically. We ride those things to 50, 55, and they do great. And there are some women, for reasons we don't fully understand, who do get some breakthrough symptoms. And what we tell our listeners, our patients, everybody else is, if something is happening, please come talk to us. Just tell us. Because we can't solve a problem we don't know about.
we don't really have good data on looking at people on the pill for symptoms. So it's really hard to know. We're really in a data-free zone. FemHRT had ethinyl estradiol in it, right? The same estrogen as the pill, and we used to prescribe it. But, it's got a shorter half-life. I suspect my personal theory is there's some people who are probably just like faster metabolizers. So it ends up having a much shorter half-life. It's because it's oral. Maybe if it was transdermal, it wouldn't be that way for them. And, we've all seen it. Like I've seen people who do terrible on estradiol. And then I'm like, let's just try Premarin, man. That's like the old standard.
Yeah.
Sometimes, I mean, I got to tell you, back in the day when it was Premarin for everybody,
they felt great.
And it's got all these different molecules and it's, some of them are SERMs, some of them are estrogens. And I don't know, it just feels to me like it was this kind of magic soup, really. So, we all metabolize things differently, right? Maybe in 50 years, we'll be able to do like DNA tests and say, oh, your like liver enzyme has this. But
yeah, no, that's a good point.
But it's like your point with how puberty is different for everyone, perimenopause is different for everyone, how you respond to medications is different for everyone. Like there's just no one size fits all. It's just that's not the way it works, which is the theme of the podcast. But
So I want to start us talking a little bit about menstruation because of the book Blood that you wrote. I think there are a lot of times in a woman's life where menstruation can become problematic. There are the rare unicorn women who have perfectly even menses through their entire lives, and it lasts 3 days, and it's very light, and it never bothers them. But that's not most of us. I mean, things wax and wane and change over time. But I think perimenopause can kind of represent a unique kind of menstrual hell for some women. Can you talk a little bit about, the physiology of what is going on and why suddenly kaplooey?
A lot of people have been taught that the menopause transition or perimenopause is this sort of like orderly decline. Like estrogen levels are here, then they're here, then they're here, then they're here.
There's some great charts of that online,
Yeah, I know,
on the
right?
internet.
Just this nice steady slope.
Yeah.
When in reality, it is like up and down, which is kind of how it starts too. And so we can have cycles where estrogen levels are much higher. And I think people really forget about that, like with loop ovulation. And so you can basically get almost like a double ovulation. You get super high estrogen levels, which can make people feel awful. And then you can swing from very high to very low. You may not ovulate, or you may have just a cycle, where you do actually get menstruation, but there was no progesterone withdrawal because it's just related to, having been exposed to a lot of estrogen and then the estrogen was withdrawn. And so you get all these permutations and combinations of high estrogen, normal progesterone, high estrogen, no progesterone, maybe normal estrogen, no progesterone. It's just kind of all over the place. And a lot of women are really sensitive to hormonal fluctuations, and it's not, the actual level, right? So, because in pregnancy, people have sky high levels of hormones, but they do actually go up pretty slowly, right? But think about then postpartum, what happens? Boom, you have this crash, and that, may be part of the trigger, obviously, for postpartum depression. Or with your menstrual cycle, it's the withdrawal of progesterone that can trigger menstrual migraines, for example, or withdrawal of estrogen. Both probably. Can't remember now off the top of my head. And it's the estrogen. And the introduction of the progesterone is what can trigger PMS. And so you have, it's these fluctuations. And some people are just a lot more sensitive to that. And whether they have super onboard receptors that are scavenging things, whether they have a different intracellular sort of intracrinology with their hormones, right? Because we have these very blunt tools. We can measure serum levels, but there's also a lot going on in the cell. You could have conversion between estrone to estradiol or back and forward. You can have conversion to testosterone. We don't have any way of knowing what's happening. And so it's entirely possible that people who are more sensitive to these fluctuations have something going on inside their cells. And so we just kind of have to accept that that's the experience. And until we get better studies to kind of tell us, how to manage that, we just have to say, well, it's almost certainly based on the best of our knowledge that the fluctuating hormones are hard for some people. And that's why some people do really well on the pill, but not everybody does. And that's okay too. And some people do well with just supplementing some low levels of estrogen. So that way they don't kind of have those crashes. Sometimes it's just trial and error, which is really hard because I think most of us think, well, you should just have the answer. But a lot of medicine is trial and error. And part of the problem is you have all the charlatans making promises, right? To them, there's no trial and error. They just have the answer. And so, you're trying to be ethical about it when you're talking to people.
I don't use the words trial and error because people sometimes don't like to hear error. I call it try and try again. We're
Right.
just going to keep trying till we land on the answer for you. I was really pleased to pick up on one thing that you said, which was you just have to listen to the woman in front of you, right?
Yeah.
She can tell you how she is feeling. And then we can help to interpret that feeling and understand what's going on physiologically and help her with that.
Right. There's a couple of kinds of tools in the toolbox. Like we can suppress your ovulation. We can do that a couple of different ways. We can just stop the bleeding from your uterus. We can supplement with low levels of hormones. And it's just as long as you know in advance that, look, we're going to try this, see how you feel, kind of go from there. That's kind of the open discussion because sometimes people come in with really strong feelings about one or the other. And sometimes it's misinformation from online, but you just kind of give people that information and let them, and that's really the essence of holistic care, isn't it?
When I talk to other OBGYNs, especially young ones or residents, I say, when I started in the perimenopause and menopause field, I was like, oh, you're in perimenopause, you need a birth control pill, we must suppress ovulation. Like hormone therapy is not going to do anything. And then I finally just sort of loosened up. I'm like, okay, what's the harm in trying this? Maybe it will blunt those lows. Maybe this person will feel better. And if not, we can always change, right? And some of that is maturity and being, okay, I can be a little more flexible.
Yeah, exactly. And, now we have other tools, right? Like we have Slin, and NoraB works for some people, so we have an ever expanding kind of repository of tools. I think it's just kind of understanding like which box each tool fits in. So you're, okay, if this box doesn't work, we're not going to maybe keep going back to that same box. We're going to maybe let's try the different box and, see.
Okay. So, since we're talking about solutions and kind of therapies and things, we've talked about solutions for bleeding before. So, getting back to your newest book about bleeding before on this podcast. But when you're seeing someone in your office, like what's your go to? And is there like anything you don't really like to use in perimenopause? Like when people are coming in and their main complaint is all this irregular bleeding or heavy bleeding or whatever. How do you manage that? And then also like, what if they're having menopausal symptoms on top of it?
I don't have anything that I don't like, although I got to tell someone if they're bleeding all over the place, progesterone's probably not going to help that much. It's not very effective for bleeding. But, sometimes people have to figure that out on their own too. I have a lot of discussions like, okay, you're the one who has to take the medication and you're the one who has to have the side effects and you're the one who has to wait to see what's going to work. And you're the one, if you're worried about this medication or that medication, it's fine if something's synthetic, it doesn't mean anything bad. If bleeding's your issue, a progesteron's almost always going to be better for you. And I explain why, but they don't want it. That's okay. Sometimes people have to figure things out themselves. Sometimes they're okay. Like everybody's a different trade-off. And I don't know if I really have a go-to. I have like, these are all the options we have for you. We have a hormonal IUD. We have birth control pills. We have, if bleeding's your issue, I'm going to really try to steer you towards a progestin. If we're going to, go orally, you can do a birth control pill without estrogen. If it's heavy bleeding, then there's tranexamic acid. Like, you can even take ibuprofen if you want to try that. So I really have like the whole, like, here's the least invasive. Here's the most invasive. I'm not a huge fan of ablations, but sometimes that's what somebody wants, and explain the risks and benefits.
We as gynecologists are like, no, don't scar the cavity. But I did them too. I totally agree with you. Sometimes that's what they want. Sometimes for that one patient, that's the right answer.
We've talked about it's a temporizing measure that sometimes can be the bridge to get somebody through this perimenopause. And then you just sort of hope and pray that you never need to go back in that uterus.
Yeah. I mean, or if you have somebody who's saying, okay, they're having a lot of trouble with their hemoglobin A1C and, they're bleeding all over the place and they're anemic, they're coming in for transfusions and this isn't working, that's not working. Or they're like, I can't take any time off work. Like it's a lot of times that, again, on social media, you hear all this, you must or you must. And I think those people must not talk to a lot of patients.
Right.
Because the longer I've been in medicine, and the longer I do anything, whether it's complex vaginitis or complex menopause, the more I'm like, here are all the options because you have to live with that. And, I still remember like many, many, many years ago, I saw somebody who, this is when I was still doing OB. This was before all the complex screening we have now was like basic alpha fetoprotein or something. I don't remember and it came up with like a 50% risk that she was going to have, some kind of, chromosomal abnormality. She said, oh, that means there's a 50% chance I won't. And I just
She's
thought,
right.
wow, yeah, you're right. I mean, it's just everybody looks at things differently. And sometimes I know it frustrates people. They're like, well, can't you tell me what to do? And I'm like, I can't because I might make a different decision than you. I have a different life that I'm living. I have different goals and expectations. And I mean, sometimes there's a clear choice, like you're at very high risk for endometrial cancer and but then I'm not going to offer you an endometrial ablation, right? If I think it's a really bad choice for you, it's not going to go in the list. And then if they ask, I'll explain why. So I think that yeah, there's always so much room for trying things that I think at the end of the day, that's what people really appreciate, even though I get it. It's like, when my contractor's here, well, do you want this or do you want that? And I'm like, I don't know. What do you think's best? He's like, it's your house. Like, sometimes, like it's the same thing.
Yeah.
So for our listeners out there, we do have an episode that hasn't been published yet all about contraception. And we really dig into sort of the pros and the cons and why we use it in perimenopause. Obviously, one of my fave topics of all time. Generally, most of those will help with bleeding. And so if you're interested in kind of looking more at all these different options, if you're, a listener out there who's having bleeding issues, that episode is coming and you can arm yourself with some more information as you're working through, your journey and what works for you.
For any international listeners, I mean, we don't have the pill here with estradiol, right?
But we used to. It didn't go over that well, though.
Yeah.
I tried it a few times, especially in the perimenopause. People had a lot of bleeding on it. So,
well, it has the 4 different levels of the progestin in it, which just, I don't know what's happening with that.
Don't know what they were thinking.
I just think having the bigger toolbox you have, the better, because sometimes you'll say something, people be like, oh, that's the one I want.
Yeah, totally. And I'm always like surprised when it's something where I have like a clear idea of what I think it should be. And then they go over to like option Z. And I'm like, that is not where I thought this conversation was going to go, but let's go for it.
And sometimes I'm just fascinated by why. And I'm like, oh, I never thought about that. Like it just, this is my reason, or, I've got a lot going on in my life and I need to just do something for 3 months to just get through it.
This is where I always talk about the art of medicine. There's sort of the science and then there's the art. And the art, you can't teach it. You have to learn it. I mean, maybe you can teach it a little bit. You can, for your residents and students and stuff. But this is where the secret sauce is. I mean, this is where, you're not an automatron. You're a human physician who is talking people through all these nuances and following your patients in the course of the conversation that to lead you where they feel like they need to end up. And you're just along for the ride. You're there to help guide them.
The thing that I find really sad is when people come in and they won't listen to one of the boxes because of misinformation that they've heard. And they're like, I don't want to hear about the pill at all. I don't want to hear about it. It's bad. It's dangerous or whatever they have to say. Or I don't want to hear about an IUD or this. And they just have I only want this. And you're like, ooh, that's actually probably not the best thing for you. And these are all the reasons. But at the end of the day, I mean, if it's not a bad choice, like a medically bad choice, then you do it. But it's just, that's always sad when people come in and they've kind of limited themselves based on basically being lied to, or misled by other people.
I actually changed all my counseling around the birth control pill and perimenopause because there was so much on the internet for a while, and it's still there, saying, if your doctor just throws the pill at you, they're not listening to you. And so I literally changed the way I counsel patients. And I'd say, I'm going to tell you about all the boxes, and I'm going to tell you why I am offering each of these boxes. And I'm going to offer you the birth control pill, and I'm going to offer it to you because I think it can do this, this, and this. And it's not because I'm not hearing you. It's because I am hearing you. And this might be your best choice. I literally have to spell that out in so many steps because they've been told ahead of the appointment that if you hear this, then run because they're not hearing you.
Yeah, it's really a disservice. I am sure if I cornered one of those doctors and said, hey, can you explain loop ovulation to me, that they wouldn't be able to.
How often do we talk about the vulva?
Us? Every day, all day.
No, I mean normal people, not us.
Oh, almost never. The vulva is basically the forgotten middle child of anatomy.
Right? And half the time people don't even know what it is.
Yeah, because it gets mistaken for the vagina all the time.
But they're different, totally different. Different functions, different problems, and different needs.
And when something goes wrong with the vulva, most people have no idea what to do or where to turn.
That's where we come in.
Absolutely. I'm Dr. Meredith McClure.
And I'm Dr. Ashley Fuller. This is Labia Logic.
We're here to talk about the body part that nobody talks about, but really should.
We specialize in vulvar health, sexual wellness, and helping women figure out why things itch, burn, or just aren't working like they're used to.
We'll cover everything from why pubic hair is actually useful to why sex hurts sometimes, and more importantly, how to fix it.
And let's be real, if you ever thought, wait, is that normal? This podcast is for you.
Join us for deep dives into all things vulvar health, sexual function, and how to actually get the care you deserve. Plus, some laughs along the way, because a podcast called Labia Logic can't take itself too seriously.
Your vulva has a lot to say, and we're here to translate.
Find Labia Logic wherever you get your podcasts.
The other thing that you address, or one of you address many things in your newest book, but one that I think is a really important topic is PMS or PMDD, which are basically mood disorders that are related to your menstrual cycle. And we see this become a much bigger problem for some women in perimenopause. So how do you approach this in your practice?
I think it can be really complicated to sort out, what's worsening of, PMDD or transitioning from PMS to PMDD and what's underlying depression, what is a pre-existing depression that's getting worse. And this is where, really listening, trying to get, a menstrual diary if possible, just to kind of see what's going on. There are these groups of women whose cycles get shorter, before they start to lengthen out, and where they lose their days are in their first part of their cycle. So the part where they feel good, say they had 14 days of PMS a month and 14 days of not. And so if you're losing 4 days of feeling good, then all of a sudden it's 10 days of feeling good and 14 days of feeling bad. And that might not be enough time to recover so all of these things come into play. This is where, trying to find out, do you have a pre-existing history of depression? Of course, also all the holistic things, what else is going on in your life? Making sure somebody doesn't have iron deficiency. If you have a symptom, you have a uterus, you need your iron level checked. You need a ferritin level because it can cause brain fog and depression or be a cofactor and all of those things. And so, if they're starting to have irregular cycles, I talk with them about probably the most evidence-based option for them is going to be a birth control pill taken continuously so they don't have that. I also offer antidepressants, which are also very evidence-based for PMDD and PMS, which also are unfairly demonized by a lot of influencers online.
Yep.
And even for depression in the menopause transition and in menopause, the SSRIs have been studied.
They work. Yeah.
We have data.
Great.
It's not wrong. And they may be even synergistic with estrogen. And so, again, that's where people do disservice. If your doctor offers you an antidepressant, they're not listening to you. No, if they only say you can only have an antidepressant, maybe they're not listening to you. But if they say, here's the toolbox, and these are these things that work, like if I have someone who comes in and their depression has become worse in the menopause transition or early menopause, and previously when they had depression and they were on venlafaxine, it was like a miracle for them. I'm going to be like, okay, let's not reinvent the wheel. You have a drug that worked really well for you that that you liked how you felt on it, right? So everything's always so nuanced. But yeah, PMS, PMDD can absolutely be worse in the menopause transition. And again, we're seeing more of the cycle chaos. And that's very problematic for people who have that kind of, sensitivity to the chaos.
I often explain to women that we talk about the ups and the downs of perimenopause. And when those hormones go up, they can really go up. And that can very much impact the brain. I mean, the brain is very sensitive to hormones.
Oh, yeah. I mean, some of the estrogen levels, you're like, woo.
I know.
You're just doing an infertility cycle? Like, what the hell?
I know. It's crazy. And they go up fast and they come down fast. I think the down can sometimes be the real kicker.
Yeah. So, I think it's just, again, important to say, these are the most evidence-based tools in the toolbox, but it wouldn't be wrong to try other things.
Yeah. And, I've had a lot of patients come in with PMS or PMDD who are asking me for micronized progesterone, the menopausal hormone therapy progesterone. And I do explain to them that for some women, this has the opposite effect. Like it can actually worsen their depression. So we need to be very careful using that. I'll try it if they really want to give it a shot. But we're not scaring you away from it because we don't want you to take it. We've seen this happen.
Yeah. I don't think that we have any evidence-based medicine to support just prescribing, progesterone for, worsening mood or symptoms. I think what a lot of people don't realize is a lot of the progesterone folklore comes from the 1980s from a physician. I think his name was, I'm not going to say his name because I might get it wrong, but they were a family doctor who became very obsessed with progesterone being the answer to everything. It basically, him and this other guy are the ones that coined the phrase bioidentical for hormones. It's not a true medical term, right? then Christiane Northrup got it from them, and it sort of became this thing. And so it's all like the naturopaths, a lot of naturopaths are like very into giving this progesterone. It's all related to this lack of science in the 1980s from this one group. And so it's hard when they read about it online or hear about it online, when they maybe go to see someone and they look it up and they don't go to the right place. And so it's just there's so much sort of natural progesterone lore that it's really hard to undo it. And, I've done a deep dive, but yeah, the whole bioidentical thing, it's just crazy. The first time it appeared in the literature is a letter to this like really alternative medicine journal in the 1990s. Of course, you can't get any of their issues online. So I actually emailed the editor and I'm like, look, I will pay you $60. I just want that letter because I want to see it. Like I want to see the source document.
Right.
Yeah.
Oh, cool.
Oh my God.
I want to make sure we have time to talk about pain. I spent a lot of my career dealing in the chronic pelvic pain space. And one thing, if you work with women for any amount of time, you realize is we will always minimize our own pain. And we are sort of taught and raised to believe that pain is just part of being a woman. Pain is just part of what you're going to go through with menses. And you just need to suck it up. This can actually get worse in the perimenopause. And no woman should be sucking this up. You don't get a prize, right? Like, there's no blue ribbon at the end of this journey if you used nothing and you suffered through.
Everyone gets a participation trophy. Yours is not going to look any different.
Yeah.
Yeah. Yeah. No, there's no first past the post here. Yeah.
Yeah.
Lots of different pains can happen. And if we're thinking, mostly about like pelvic type gynecological pain, I mean, absolutely. I mean, I've seen people develop their first bout with endometriosis in their mid 40s because guess what? They're shooting out high levels of estrogen and not enough progesterone. Or people who had it in their 20s and they were like, I was having a problem with my endometriosis for like 20 years. And then boom, people can develop pelvic floor spasm. I mean, just because of the stress. Maybe they had an episode of painful sex because they got genitourinary syndrome of menopause a little bit early, and then that triggered their muscle spasm. And then, adenomyosis, they might have painful periods from that. So there's a lot of things that can accumulate over time. And obviously, when you're 48, you're not 28, and maybe things affect us differently pain-wise. Although, I don't know really there's any data with that. But, if you also have like arthritis and you've accumulated migraines, there's like this pain burden, right?
Right.
So if you have more than one pain condition, it's all feeding in centrally. So, now you have a different situation than if you just had, painful periods.
Exactly.
Which doesn't mean to minimize painful periods. They're terrible. So I think it's important that, we see people and really think about like what's going on for you. Could this be endometriosis? Could this be adenomyosis? Is this cyclic? Do you have pain with vaginal penetration or pelvic exams or tampons? And then obviously fibroids can develop it. For some people that can, add pain. So, there's a lot of this kind of cumulative burden. I'm a big fan of writing down all the potential pain generators and writing a list and then being like, okay, what's probably more likely based on your history? What do we need to do to rule some things out? An ultrasound can help us, and then go from there.
That's really great. And, one of the things I sometimes see, you mentioned pelvic floor spasms. This is also a time of life when maybe we're not so good at controlling our urinary stream. We can get overactive bladder. We can get stress incontinence, especially if we've maybe had a couple of kids in the intervening years. And sometimes even just trying to control that can lead to pelvic floor spasms.
Mm-hmm. Absolutely.
Just doing Kegels is not necessarily the answer because you may not be activating the right muscles.
Or sometimes people get like, I've been doing Kegels all day to try for my bladder. And you're like, okay, well that,
Yeah, now your pelvic floor is tight.
Yeah, but if you're going to a gym and lifting incorrectly and you're going 3 times a day to do that and no one's told you you're lifting incorrectly, of course you might get hamstring tendonitis or something else, right? So
we have an episode coming up where we're speaking with a pelvic floor physical therapist to really talk through, okay, what are some of the things that can happen, but also what is pelvic floor physical therapy? Because I think it sounds a little daunting.
I've been referring people to pelvic floor physical therapy for, over 30 years, right?
Yeah.
It's so amazing to me how I feel like almost every time it's like I'm explaining to someone for the first time. And it's really weird because if you mention endometriosis, a lot of people have heard of that, right? They've heard of it. Or if you mention an IUD, or you mentioned lots of other things that we talk about every day.
Right.
But it's so weird that that's just like, that hasn't made the leap. And obviously, you know, we're all in a bubble because we talk about it all the time. But I just find it fascinating that that's like the thing that hasn't made a leap. And I have a theory.
What's that?
So because it also is used to treat, you know, incontinence and overactive bladder, and heterosexual men don't care about your incontinence. Heterosexual men care about you not bleeding all over their penis. And so I have a theory that that's why women's magazines don't talk about it. Like, they only talk about like vaginal discharge and pubic hair because those are the things men care about. So that's my personal theory. I have nothing to back it up, but it just doesn't spark out into the lay press.
It doesn't go well with the article on how to be your sexiest at 55.
I mean, it could. I mean, when you've got a rockin' pelvic floor, it's awesome. But, you know, the kindest thing a man ever said to me was, "You have a pelvic floor of a 20-year-old." I was like,
that's such a compliment. Everything in our society is through the male lens, right?
Absolutely.
So it's like even the women's magazines are
Right.
about how to make yourself better for your male counterpart. None of it is really about our actual self-care or our, like, how to make ourselves feel better for ourselves. It's all about how to make yourself, quote, better for the male
Mm-hmm.
audience. It's all fucking bullshit. Excuse my language.
I really believe that. It's like all sort of the patriarchy in disguise. And look, I want the jeans that fit me the most too. I'm not saying like some of those articles that aren't great, but when you look at like their health stuff, it's got a very weird bent, because why aren't they talking about incontinence? Like, that's a really common problem that no one discusses, but like you never see that, right? And it's like they make women paranoid about their vaginas. And then they have these other things they could be talking about, like every 2 or 3 years, one of the women's magazines rediscovers endometriosis. And I'm like, so you only thought it was worthwhile to cover like every 3 years? Like,
Right.
you can say doctors suck in talking about that, and lots of them do. I mean, we're hoping that that's all improving. But if you're like not talking about it every month, but you're talking about like pubic hair all the time,
Because that's important for our health.
again, it's great to have articles on all different kinds of things. But if you think about like what are you actually doing to change the conversation on a regular basis? And I know someone who was, you know, on one of the boards from one of these magazines, and they basically told me if they didn't have an article every month about vaginal mayhem, the magazine wasn't going to sell.
I mean, my God.
Well, this is a good segue.
Oh, yeah. Let's
Segue into the vulva and the vagina, please. Because, I mean, this is a topic that's close to my heart. So I think I've talked about this on this podcast before. My previous life, when I had a practice where I saw patients in person, was menopause and vulvovaginal specialties. This is what I did. And I think it's just such a misunderstood area of the body. We don't talk about it, as I said earlier. But also, we as women are almost taught to fear it. Like we're bad if something is wrong with our vagina or our vulva. And we put up with so much down there because we think we're dirty or, you know, there's something wrong with us. When a woman comes in perimenopause, what specific things do you ask her about in terms of her vagina and her vulva? Like, how do you start the conversation? Because we've all had the experience where they don't mention it all. They don't mention it all. You're on your way out the door. They're like, oh, and
by the way.
So I asked, are you having any vaginal dryness? Are you having any irritation? Or you use tampons or menstrual cup? Any pain with those? Would you find you're having any chafing, itching, you know, any symptoms? And sometimes I hear no. And then you do an exam and you're like, let's ask that question again. You know, and sometimes people are like, oh yeah, thank you for asking. You know, sometimes I might wait and see what happens with the exam, because obviously if you look and someone's got excoriations from scratching, then, you know, re-ask again. Because a lot of times, unfortunately, people don't know that what they're experiencing is abnormal, right? They think it might be normal to scratch, especially if their mothers do that. It's like, how do you know your periods are heavy if no one actually ever defined what a heavy period is?
Mm-hmm.
So one thing that I wish every doctor and every person who goes to a doctor would do this is, people will say, well, I have itching sometimes, or I have some discharge sometimes, or I have this sometimes. I'm like, what does sometimes mean to you? Because I can tell you after 30, 35 years of talking to people, sometimes can be once a month for 2 minutes. It could be every day, all day, but it's just only the times when it's driving you crazy or thinking about it. Like there's such a range to what sometimes means or what the bother factor is. So I think that that's something that I'm always trying to drill down with those symptoms. Like, what do you mean by sometimes? And the looks, I'll get someone's like, but if no one's
Nobody's ever
asked you
asked
before,
me. Yeah.
right? So, I ask about that. I'm big on talking about, like, hey, as we get older, our skin gets drier everywhere. Menopause can also accelerate that a little bit on the vulva. So, I'm big on talking about like, what are you doing from like a basic hygiene? Are you using a soap as opposed to a cleanser? I always ask about, feminine hygiene things, washes, because, that's my personal like
Oh,
Yeah.
God.
nemesis. I'm just like, hey, you can just use a gentle facial cleanser. You can use it on your face, you can use it on your vulva. That's good. You're good to go. If you're happy with water, that's okay too. These are kind of some options. I always say you're probably going to get ads for like V Magic or some other special vulvar balm. And you know what? Vaseline works great. You don't have to spend a lot of money. If you like those products, great. I'm also always warning people away from don't use something with tea tree oil in it because that can be an irritant.
It's a huge irritant.
Be careful about that. I also warn people about all the lubes with all the like the warming stuff.
Or scented or flavored.
Yeah, or some of them have cinnamon in, which can cause a profound irritant reaction.
Just PSA.
Yeah.
Please don't put cinnamon in your vagina.
Yeah.
Thank you.
So, no, seriously, I looked it up. I was like, what has inflamed you? And, my partner bought this lube because he wants to spice things up. And I'm like, okay, well, this, just use it. And I also talk about what I think's the best lube, which, if people, because a lot of people aren't using a lube or they don't know who to ask. And so I'm like, look, a silicone based lube is like your great entry point. Like, and generally in menopause, it tends to be the best tolerated. Look, if you love your water based lube, great, you stay with it. But if you don't have one on hand, you might want to keep one. I usually just recommend Astroglide X because you can get it everywhere. Pure, like, there's no need to spend. I was like, there's no bespoke silicone product.
They don't have the better silicone.
Right. Like you don't have to know your farmer.
Right.
What I do a lot of is actually trying to save people money.
Right.
Because people come in and it's not like that, using whatever fancy balm on your vulva, as long as it doesn't have like irritants, they're usually just a whole bunch of different like overpriced oils. I'm like, you could also just use coconut oil then if you like an oil.
I know. You can go to the grocery store. I do tell them to get the one that's not chunky.
Yeah. So I'm always just like, I feel like I'm always just trying to be like, there's less expensive products. And Vaseline is great. If you like A&D, great. But if you're getting an irritant, just remember 4% of people are allergic to lanolin. So, just keep that in mind.
I always give my patients a list of silicone lubes. I say, all of these are fine. This one has a nicer bottle. You're going to pay for it. But yeah. I do tend to steer people away from water-based lube unless they already have one that's working well for them. Like, just because I find it absorbs over time, like it gets sticky. And the last thing you want in perimenopause or menopause is sticky.
I think that, probably if you were, that silicones, and then you don't have to worry about the osmolality and have they changed the recipe, or their formula or whatever. So that's why I like silicone because it's like, it's a no brainer. But, like I said, if someone's like the slip feel of, it's just like, how some people hate the feel of certain fabrics.
Yeah.
And so, if you like that, okay, great.
Yeah. Perfect.
So last, but definitely not least, we've mentioned this before, in prior episodes and also in this episode where we talked about I love the use of the word charlatan. It's such a great word. But, menopause, perimenopause, having a moment. Love that it's having a moment, but we have all dealt with, like you said, the folks who come in with this misinformation where they've been lied to, essentially, or given sort of interesting interpretations, I will say generously, of the data. So what sort of tools or how can we help laypersons or even physicians who aren't all that knowledgeable in perimenopause and menopause, like judge the quality of the information that's out there?
You have to do what's called lateral reading. So meaning you have to move away from the source that you're getting the information from, open a new browser and search. And that sucks and it's boring and we all want to just follow another reel after another reel. But if you're going to listen to any medical advice online, and this is the same for providers, you need to do that. And so I kind of have a couple of quick and dirty tips that I think work really well. So one is that person selling you a supplement? And I will die on this hill that that is not someone that you should be getting health advice from. First of all, it injects bias into everything that they're doing. Because if you make fantastical claims, you're going to get more views on your website, and that's where you're selling your product, right? But would you get information about the HPV vaccine from Merck? No. You would want to get it from an independent source. You don't want to get it from the person making it or making another product that they might somehow. So there's that. But when you do a deep dive and look at the supplements, whether, this covers a whole range of people, like a lot of people across different medical specialties, people who are PhDs, people like Andrew Huberman, and you actually look at their data, it's like, okay, so 5 out of your 8 studies are on rats that are supporting your supplement. So that tells me you either don't know how to read the literature or you don't care. That's problematic. If you think this is good homework, then I don't trust anything else you have to say. So that's my big bias about that.
Because rats are not people.
Right. Yeah, women are not rats. Maybe this turmeric supplement was designed for a female rat, but whatever. So that's one of those things that I use. The other is I look to see who they're associated with. Are they associated with anti-vaxxers? Are they, so I Google people's names like Anne Christiane Northrup, who is one of the top 12 disinformation spreaders in during COVID, who's full on QAnon. And she's always been like this, right? It's just now more open because I read her first book. Did you know she consults and she used to consult an intuitive to decide about fibroid surgery?
I did actually.
Yeah, isn't that's great? That's just what you want in a surgeon.
Yeah.
Like Christiane Northrup, I Google their name and, Mark Hyman, I Google their name and, RFK Jr. Like I want to know who they're associating with, because if I showed up at a conference and I was going to speak with one of those people, I would just leave. I'd be like, I'm not going to give them, my credibility. And then the third thing is, you can't just do a Google search for a topic, but what you can do is you can put your question in like hot flashes and you can put in North American Menopause Society or Menopause Society or Australasian Menopause Society or British Menopause Society. You can put that under ACOG. So you can put in the name of a medical professional organization that is trustworthy and your question that will work for the search engine optimization. Because if you just put in hot flashes, you're going to get what's popular or what's been sold or, all these other things that will fix it and come to the top. The problem is the more somebody who isn't evidence-based gets cited, the more their stuff comes to the top and it starts to the expertise looks like it compounds. And so that's what I do. And then finally, I'm like, if people are only talking about hormones, if they're only talking about hormone therapy and they're not talking about birth control pills, they're not talking about antidepressants, they're not talking about neurokinin 3 receptor antagonists, they're not talking about cognitive behavioral therapy, they're not talking about bisphosphonates. If they're not talking about the whole toolbox and they only are talking about hormones, then that tells me that when they don't understand the whole toolbox, so they're not a menopause provider, right? But also on social media, and I've seen this myself, if I do a reel on hormones, it gets tons of attention. And if I do a reel on antidepressants, it doesn't. If I do a reel on, neurokinin 3 receptor antagonists, it doesn't. And so if you're trying to build a business, then you're only going to do what's popular. But if you're trying to help people, then you're going to have this wide range of experiences. And so those are kind of like the tools that I use. And, people consider me mean or hardcore. And I'm like, I just think people deserve high quality information. And like my son just had open heart surgery last year. What if he got sucked down some rabbit hole and decided not to have that surgery because of some supplement person? Like if his heart surgeon was like doing Reiki, I'd be like, we're going to find somebody else because I'm sorry. Like somebody who believes in Reiki is not somebody who I trust to interpret the literature. I'm really just doing for people what I would want for myself or what I'd want for my children.
Yeah. And, I think that's a really great note to end on. Because I think the last thing you brought up is that women deserve excellent information. It's that simple. Like we deserve the truth as we know it based on science right now. Because, science is tough. It changes over time because we keep asking questions and we learn. But, that's the best thing we can do for women.
Yeah. And it's really hard because nuance just doesn't work.
It doesn't sell.
Yeah. It's a lot easier to tell people that you have a definitive therapy for brain fog or you have a definitive therapy for that than for say, well, actually no one's ever studied it, so nobody could have a definitive therapy. You can't be empowered with inaccurate information. And you can get your information wherever you want, but don't you also want to fact check it against something? So then you can say, well, I made an informed decision because you're not informed otherwise. When we see people who go get hormone pellets, we know they didn't get informed consent because we know they weren't told about all of these side effects and weren't told about the higher rate of hysterectomy or endometrial cancer. They didn't get informed consent.
I mean, I think our other public service announcement, because we've had a couple in this podcast, is if a physician or a medical office is selling you something for cash, it's not going to be paid for by your insurance company, but they're selling you something, it really brings into question their ability to be unbiased in their counseling to you. And they're in it for financial gain. And when a physician is in something for financial gain, it's very difficult. And we all start like, I'm not going to be the one, I'm going to stay true and evidence-based, but it's a very slippery slope. And I'm not saying that these folks are bad people. I'm not, but you have to be very careful and suspect.
I tell patients, there are variations. I think we're really strict about this in OBGYN. We see dermatologists who sell their own lotions and products. We see plastic surgeons who do this. It's not considered as ethically fraught to them, not saying to us, but to them. But if someone is telling you this is the only product or the only pathway that is going to solve your problem, then please run.
Or their product is more expensive, right? AMA Code of Ethics actually says physicians shouldn't be selling things. They make exceptions for like if you live in Coffeyville, Kansas, and your patients can't have difficulty getting vaginal dilators, it's absolutely totally ethical to sell them in your office at like cost with like whatever your dollar markup to count for your staff doing everything. That's totally fine. Or you're selling walkers because people can't get them because there isn't a medical supply store. We're not talking about that. And ACOG actually is very like, not that they enforce any of it, but they also say it's not ethical. It's so easy. I've been doing this for so long and I see all these people who say, oh, it's not going to affect me. It's not going to affect me. And I'm just like,
it always does.
You see people making reels about why you should never get hormone tests, how they're not indicated over the age of 45. And then, a month later, those people are doing ads for Clear Blue home hormone testing.
So thank you so much for being with us today, Jen. I mean, it's just been such a wonderful conversation. And I so appreciate your stance. I so appreciate you being out there on social media because we're not as good at it and somebody has to do it.
I know there's some days I'm like, what? But I got a lovely message today from a nurse practitioner who said, my content has inspired her to become a certified menopause practitioner.
Yay,
She's made an exam and she loves that I'm just out there talking about like the evidence and that's how she feels. And so I'm like, oh, that makes it all worthwhile.
It does.
Oh,
it does.
That's wonderful. Well, dear listeners, we thank you so much for tuning into OvaryActive. And remember, you're not crazy. This is really happening.